Hi class, in this lecture we will review drugs used to treat peptic ulcer disease and gastroesophageal reflux disease, also known as PUD and GERD. The objectives are listed on the slide. They're also listed in your Blackboard module. There are several vocabulary terms that you should review. You can find the definitions for most of these in your textbook. So there are a number of medications that are used to treat PUD and GERD. I have them broken down on the slide based on how they work or what they're targeting. So you can see that for the eradication of H. pylori, which is a bacteria that can be found in the GI tract, we're going to need antibiotics. That should make total sense given that H. pylori is a bacteria. Those antibiotics are going to be coupled with acid suppression as well. So the drugs that will suppress acid or decrease acid production, also known as anti-secretory agents, they include the H2 blockers, the proton pump inhibitors, and the prostaglandin E analogs. And then finally, we have drugs that will neutralize the activity of acid or pepsin or both. So we have the mucosal protectants and the antacids. We're going to start by talking about the antibiotics that are used for H. pylori. So I talked about Helicobacter pylori or H. pylori in the patho review lecture. If you're not familiar with H. pylori, you might want to go back and listen to that particular lecture. Bottom line though, H. pylori is a gram-negative bacillus. It colonizes the stomach and the duodenum. It lives between the epithelial cells and the mucus barrier within the GI tract. It can live there for decades. It's estimated that upwards of half of our population has Helicobacter pylori colonization. However, only a small number of people become symptomatic with peptic ulcer disease. So eradication of H. pylori with antibiotics promotes healing and it minimizes the risk for recurrence. Recurrence rates in patients for whom H. pylori has been eradicated are very low, just around 10%. Whereas patients who don't have effective H. pylori eradication, their peptic ulcer disease recurrence rates are as high as 80%. So it is the gold standard to provide H. pylori eradication to patients who have an ulcer who also test positive for H. pylori. So there are guidelines from the American College of Gastroenterology. They're detailed in your textbook. You can take a look. The guidelines outline the different regimens, including exactly which drugs, which doses, what frequency, the duration. That level of detail we will not ask you to memorize, but it is in your textbook if you're interested. What we want you to know is just generally how are these ulcers treated. First of all, you should know they are treated with antibiotics. Antibiotics will eradicate the H. pylori, of course. Again, H. pylori is a bacteria. But we don't just use one antibiotic, and this has to do with minimizing the risk of resistance. So we always use at least 2 antibiotics, and really with the most recent guidelines, preferably 3 antibiotics. So I have the antibiotics listed on the slide. You should definitely be familiar with these different antibiotics. We will learn these in full detail in a couple weeks. But for now, just know that these are the antibiotics that are used for H. pylori eradication. Amoxicillin, I know you've all heard of that drug. It's a beta-lactam drug. It's very commonly prescribed. Clarithromycin, or Biaxin is the brand name. Clarithromycin is a macrolide. Macrolides, other macrolides you may have heard of, azithromycin or Z-Pak. I know many of you have probably heard of that. You may have administered it, or some of you may even have been prescribed that medication. It's used quite frequently for community-acquired pneumonia. But for H. pylori, the macrolide that is the drug of choice is clarithromycin. Tetracycline, another drug that's been around for a long time. Metronidazole or Flagyl. This is a very commonly prescribed medication. I would guess that many of you have administered this. And then the last antibiotic is bismuth subsalicylate. And so many of you are probably scratching your head now thinking, wait, I've heard of that. In fact, I think that's Pepto-Bismol. And if you thought that, you are correct. Bismuth subsalicylate is an over-the-counter medication which is contained in Pepto-Bismol. It has antimicrobial properties, and it is those antimicrobial properties that make it useful for the treatment of H. pylori. Now, as I said, these antibiotics are combined with acid suppression. So in subsequent slides, we'll talk about the proton pump inhibitors, or PPIs, as well as the H2 blockers. Some regimens call for a PPI and some regimens call for an H2 blocker. So in terms of these regimens, as I mentioned, it's either triple therapy or quadruple therapy. Quadruple therapy would consist of 3 antibiotics combined with 1 acid suppressing agent, and that is the preferred regimen. These medications are given for 14 days, preferably. There is also an option for 10 days, but the eradication rate is slightly lower with the 10-day regimen, so the 14-day regimen is preferred. There are quite a few issues with H. pylori eradication regimens. As you can see, there are quite a few medications contained in these regimens, so pill burden is substantial. Adherence can be a problem because of pill burden, because of adverse effects, for example, nausea, vomiting, and diarrhea, which are all quite common with antibiotics. These can be problemsome for patients, and also this regimen is pretty expensive. So these are all things to think about when you are educating patients on these regimens. And really, in the end, what we want to do is help the patient with the cost, help the patient with ideas for adherence, help minimize pill burden whenever possible, and also minimize adverse effects. These are just some examples. You don't have to memorize these, but I just wanted to give you a feel for what these regimens might look like. So to the top left, you see the Omeclamox pack, and this, as you can see, is a card. So this is a box. It would contain patient cards, and so there is a card for each day of therapy. This is a 10-day pack, and so you can see that on the left side is the AM dose, and on the right side is the PM dose. And so this includes omeprazole, clarithromycin, as well as amoxicillin capsules. The product on the bottom is Helidac. So Helidac, you can see, is given 4 times a day. Helidac consists of bismuth subsalicylate, that's what those 2 big pink pills are, metronidazole, as well as tetracycline, and this has to be given 4 times a day. So again, think about adherence. 4 times a day is quite a substantial pill burden for patients. And then one other thing to point out, this doesn't even include the PPI. This is just the antibiotics. So the patient would purchase the Helidac, and then they would have a separate prescription for the PPI. So I mentioned we'll go into much more detail with each of these antibiotics when we talk about the pharmacology of antibacterial drugs in several weeks. But for now, let's just talk about some general considerations that you need to keep in mind whenever a patient is taking antibiotics. First of all, the most common side effects are nausea, vomiting, and diarrhea. These are common. This is something to tell the patient about. You want to prepare them for the fact that they may be having those symptoms and potentially offer them some advice on ways to minimize those symptoms. Additionally, with antibiotics, they are in many cases cleared by the kidneys. In some cases, however, they may be metabolized by the liver. So because of that, it's really important to always consider whether the antibiotic requires renal or hepatic dose adjustment. And finally, we worry about resistance. And so for this medication regimen, we worry about patients stopping too soon and that can increase the risk of resistance. We'll talk a lot about resistance when we talk about antimicrobials a little further, but just in general, exposure, so chronic exposure to antibiotics, as well as not completing the full prescribed course of therapy, these are things that can increase the risk of resistance in the future. So it's really important to talk with patients about why it's so important for them to complete the entire prescribed course of therapy. Some drug class specific adverse effects I want to mention. With beta lactams, the number one thing we worry about is allergy. So prior exposure, even if the prior exposure was many decades prior, the patient could potentially have an allergic reaction. And with beta lactams, that's something that we look out for. Also, renal dysfunction. So patients with severe renal dysfunction will require dose adjustments, and without those, it makes it much more likely that adverse effects will occur. With the macrolides, one of the top priorities or severe problems that we look out for is QT prolongation. So this is usually not a concern at normal doses or for patients that aren't taking multiple other medications. But if they are on medications, other medications that also prolong the QT, that can be concerning, or if the patient has congenital QT prolongation syndrome. With tetracyclines, these medications should not be administered with dairy, iron, or antacids because it dramatically decreases the absorption of those medications, so that's a very important counseling point. They also can cause permanent discoloration of the deciduous teeth, which are the growing teeth in a child, and so they're not used in pregnancy or in breastfeeding patients. Finally, metronidazole or tinidazole, which is another drug that's very similar to metronidazole that could be used as part of these regimens. These medications can cause a disulfiram reaction. We've talked about that early on in this course, so patients on these medicines should avoid alcohol. They also can be involved in lots of drug interactions. And then finally, metronidazole should be avoided in pregnancy, especially the last trimester, because it can cause some reactions in the newborn. And in this this graph, you don't have to memorize this. This is really, I know some of you guys like to kind of know the why behind things, and so what this pictorial shows you is kind of what's going on with a disulfiram reaction. So and this is specific to disulfiram. So this is not necessarily for metronidazole, but if you understand how a disulfiram reaction occurs, we can kind of extrapolate that it's probably similar for metronidazole. So basically what you see here is ethanol being metabolized. So alcohol dehydrogenase is responsible for both the first and the second steps in this process. And so acetaldehyde is produced, and in patients who are on disulfiram, that actually can inhibit aldehyde dehydrogenase. So, like I said, the first step is alcohol dehydrogenase, which is responsible for metabolism to acetaldehyde. And then acetaldehyde is further broken down into acetate. And aldehyde dehydrogenase is responsible for that, the enzyme responsible for that breakdown step. Disulfiram will inhibit aldehyde dehydrogenase. So what you end up seeing is a buildup of acetaldehyde. And when acetaldehyde builds up in the bloodstream, that's when some of the side effects that we see with a disulfiram-like reaction would be expected, like flushing, blood pressure fluctuations, and some of those other effects that I explained. All right, the last drug that we're going to talk about that's active against H. pylori is bismuth subsalicylate. Brand name is Pepto-Bismol. You guys know this is an over-the-counter medication. It's typically used for diarrhea or indigestion. However, this drug does have some antimicrobial activity. It is a heavy metal that it is believed to disrupt the cell wall of the H. pylori bacteria. Some of the adverse effects that you'd want to be familiar with
you definitely want to tell patients about this. It can cause kind of a black discoloration of the tongue, can cause a black discoloration of stools. Sometimes patients get real freaked out when they see the black discoloration of stools, because most patients know that if you've got stool that's black, that is a sign that you might have internal bleeding. Or gastrointestinal tract bleeding. And so if they're not educated to this up front when they're taking this medication, they may mistake that for gastrointestinal bleeding, and they might get really worried. And so letting them know that this is something that you will see. Typically, it's temporary. It's absolutely harmless. Essentially, what's happening is bismuth is combining with trace elements, trace amounts of sulfur that's in your saliva and your GI tract, and that produces bismuth sulfide, which has a black color, and so that's responsible for the discoloration. Other can also cause hearing loss or tinnitus. So those are they're rare, but they can occur with the use of Pepto-Bismol. Individual variation: if a patient is allergic to aspirin, then they should not receive bismuth subsalicylate, because aspirin is a salicylate drug. So this drug is structurally similar to aspirin, and there can be cross-reactivity for patients who have an aspirin allergy. They can also be allergic to this medication. Some nursing implications: again, educating your patients that the drug can cause that blackened tongue or stools. That's probably one of the most important things that you want to make sure they're familiar with. And this is what it looks like. So this is a picture showing the darkening of the tongue and the oral mucosa. And in this particular case, this was related to a patient who was taking the chewable version of the bismuth subsalicylate tablets. And after a few days, that they started to experience this black discoloration. Like I said, it's temporary, and it's definitely harmless. But as you can see, if you started to notice this side effect or this effect yourself, and you didn't know that it was from one of the medications you were taking, and you didn't know that it was harmless, it might kind of freak you out. So again, kind of making sure your patients are familiar with the potential for this to occur. All right, let's move on to the medications that decrease acid production. So before I talk about those, let's talk about the parietal cell. I like this graph. I think this graph is, or maybe not graph, this diagram is a nice summary of the different drugs that kind of influence acid, gastric acid. So basically, the production of gastric acid in the parietal cell is stimulated by 3 endogenous compounds: acetylcholine, histamine, and gastrin. And so we have drugs that can influence these different pathways that involve either acetylcholine, histamine, or gastrin. So what you kind of see here is the parietal cell. You can see that activation of the muscarinic receptors by acetylcholine is going to influence that purple dot over on the right-hand side. That's the hydrogen, potassium, ATP ACE pump. Basically, what that pump does is it takes in extracellular potassium and it pumps out into the stomach lumen hydrogen ions, and that's going to contribute to acid production. And so if you block your muscarinic receptors, they can be blocked by a drug called pyrenzapine. Now, we're not really going to talk about that drug in clinical practice. That drug's not really used anymore. But we're going to talk about the light pink receptors. We're going to talk about the orange receptors. So the light pink receptors are blocked by drugs that are known as H2 blockers or H2 receptor antagonists. These are drugs that block this histamine receptor, which kind of shuts off this particular pathway, so you have less pumping out into the stomach lumen of those hydrogen ions. Similarly, the orange receptor below that is a prostaglandin receptor. And so prostaglandin analogs like misoprostol will activate that receptor. And then what you see here is kind of a turning off of the histamine 2 receptor. And so again, that's going to decrease your outflow of hydrogen ions. Other drugs that potentially impact this pathway. If you look at the purple pump, you can see that that's inhibited by the PPIs, or proton pump inhibitors. So there are drugs that directly block that pump so that you have less outflow of your hydrogen ions. And then, of course, antacids. So these aren't necessarily anti-secretory agents, but you can imagine that these antacids are going to combine with this acid that is pumped out into the stomach lumen, and they're going to neutralize that. All right, so let's look at each of these drugs that decrease acid production. So first of all, we have the H2 blockers, and you can see kind of where the H2 blockers fit into the scheme. Remember, they're going to block that outflow from that histamine pathway, and they're going to decrease the production of the hydrogen ions that are being pumped into the stomach lumen. All right, so the H2 receptor blockers. So the prototype is ranitidine. By the way, we call these H2 blockers in clinical practice. That's the term that you'll hear. The prototype is ranitidine. The brand name is Zantac. There are actually 4 different drugs that are available on the market. They're all equally effective. For the most part, they're pretty well tolerated. Serious adverse effects with these drugs are somewhat rare. There is one drug in this class, cimetidine or Tagamet, that has a lot of drug interactions, so that one, we try to avoid. But the other 3 really are, for the most part, equally efficacious. It really just depends on prescriber preference, or maybe which drug is on the hospital formulary. Really depends on what you're going to see out there in practice. So these drugs, I already explained the mechanism of action. They block the effects of histamine on the parietal cells, and that decreases gastric acid secretion into the intestinal lumen. These drugs are used for peptic ulcer disease. They're used for GERD. They're used for Zollinger-Ellison syndrome, which is a hypersecretory condition caused by a gastrin-producing tumor. For patients that have Zollinger-Ellison syndrome, they will need very high doses of ranitidine in order for their ulcers to be healed, because they are hyper producers of acid, and so they need a lot of drug. And so, this is when you're in practice, when you have a patient and you see that they're prescribed a very high dose outside of what you normally see, you need to kind of investigate that and find out, well, why is this high dose being prescribed? If you find that it's because the patient has Zollinger-Ellison syndrome, that's appropriate. If you find that it's because the order was written incorrectly, obviously it needs to be changed. Aspiration pneumonitis, H. pylori, remember, along with antibiotics. Typically we use a proton pump inhibitor for H. pylori treatment, but there are some regimens where an H2 blocker would be used. And these drugs are available over the counter. Granted, they're in lower doses, dosage strengths than what is available for prescription, but they are available over the counter for self-medication purposes, for heartburn or for indigestion. Like I mentioned, these drugs are pretty well tolerated. CNS effects are rare. Generally, they don't occur with ranitidine. That's more of a concern with cimetidine. Pneumonia is something that it can occur, and this is basically related to an increase in GI pH, which can promote bacterial colonization of the stomach, and that can secondarily result in bacterial colonization of the respiratory tract. So in certain patients who might be prone to pneumonia, we probably would avoid these medications. Patients like patients with COPD, where they might be at risk for pneumonia, we would want to avoid these drugs if we could. Drug interactions, very few, except for cimetidine. That particular drug does have quite a few drug interactions. Individual variation, for patients who have either renal or hepatic dysfunction, we would be concerned about the dose we're giving, and it might need to be lowered depending on the extent of their either renal or hepatic dysfunction. Some important nursing implications. Educating on the signs and symptoms of pneumonia. It's not all that common for patients to get pneumonia, but it can happen. And it could be life-threatening depending on the patient population. So making sure patients understand that they should look out for these symptoms is important. Educating elderly patients about possible CNS effects. Again, these drugs, specifically cimetidine, we usually avoid in elderly patients just because we know that CNS effects are possible. There are lifestyle modifications that could reduce signs and symptoms, specifically for GERD. So, educating patients on those modifications is important. Completing the entire prescribed course of therapy, even after they're feeling better, doesn't necessarily mean that their ulcer has been completely cured. So, in order to prevent recurrence of symptoms, they really do need to complete the entire course of therapy. And then, if they're also taking antacids, which is somewhat common, for patients with peptic ulcer disease to also be on antacids, those should be separated by at least an hour from the H2 receptor blockers because antacids can inhibit the absorption of the H2 blockers. All right, so the next class of drugs are the proton pump inhibitors. And so you can see in the little diagram inside that red box, these drugs are directly inhibiting that pump. So the proton pump inhibitors, there are several of these on the market. If I had to guess, I think you guys are probably familiar with a lot of these drugs. Not only would I guess that you've probably given them on your clinicals, but I'd also guess that either you've taken them or maybe somebody in your family's taken them because they're pretty commonly prescribed medications. They're also over the counter, but there's also commercials on for these medications all the time. You might have heard of the little purple pill. Omeprazole or Prilosec is our prototype. These drugs, as I already mentioned, inhibit that proton pump in parietal cells, and that blocks the secretion or dramatically reduces the secretion of acid into the intestinal lumen and into the stomach. Therapeutic uses, again, for peptic ulcer disease, they can also be used for GERD, Zollinger-Ellison syndrome, stress ulcer prophylaxis for patients that are in the hospital, but only certain patients will fall into kind of the category of who that would be appropriate for. So patients in the ICU with risk factors like multiple trauma or spinal cord injury, prolonged mechanical ventilation, these are patients that we might do stress ulcer prophylaxis on. By and large, though, it really is not appropriate to do stress ulcer prophylaxis. For our purposes, we're talking about peptic ulcer disease and GERD. So these are drugs that are used for both of those conditions. For the most part, these drugs are pretty well tolerated when they're used for short-term use. And when I say short-term use, I mean 4 to 8 weeks. When they are used for anything in excess of that, that's when we start to worry about adverse effects, such as the risk of C. difficile infection or increased risk of fractures with long-term use. Another adverse effect that has been linked to the use of proton pump inhibitors but hasn't been definitively shown to cause this adverse effect is dementia, and I'll talk about that in a moment. But for the most part, these drugs are pretty well tolerated. There's some recent data with dementia that just came out, a pharmacoepidemiologic study that looked at the relationship between proton pump inhibitors and the risk of dementia. It's kind of postulated that these drugs can have an impact on the development of beta amyloid plaques in the brain that are associated with specifically Alzheimer's type dementia. So this particular study, like I said, it was a pharmacoepidemiologic study, or also known as a pharmacovigilance study. They did find an increased risk in this particular study of an association with all-cause dementia. So not specifically Alzheimer's, but all-cause dementia. There were some issues with this study. One of the issues is there was no risk profile adjustment for the dose that was used. So, is it more likely with higher dose therapy or lower dose therapy? Some other variables weren't controlled for, things like smoking and other risk factors that are known to be associated with an increased risk of Alzheimer's. Those weren't controlled for. So that kind of makes us, take the data with a grain of salt. I think from a practice standpoint, this is pretty new research, really hit the presses in the last 6 months. And at this point, kind of what we can say is that it's interesting information, but it definitely is going to need a lot more research to determine whether or not indeed there is a causal relationship. This is the particular study that was published. So you guys are, the link to the study is on the slide, so you're welcome to take a look at that and maybe look at it a little bit more in depth if you'd like. Drug interactions. So that's something we really worry about with proton pump inhibitors. These drugs inhibit the CYP enzyme 2C19. One of the reasons why we worry about this is, number one, this is a pretty common enzyme for metabolism of drugs. A lot of drugs are actually metabolized by 2C19, so there could be drug interactions as a result of that. One that I want to mention in particular is clopidogrel. Clopidogrel is an antiplatelet drug. It is a substrate for 2C19. Problem with clopidogrel is that it's a prodrug. And so when PPIs inhibit the metabolism of that prodrug to its active moiety, that increases the risk of therapeutic failure. Now, it's pretty likely that you'd see a patient who is on clopidogrel may also be on a proton pump inhibitor. And so there has been a lot of discussion. It's kind of controversial whether or not that's appropriate because of this, theoretical risk of therapeutic failure. There's a nice discussion in your textbook about this, so definitely take a look at that. This drug can also inhibit absorption of some drugs, like ketoconazole and certain HIV drugs. And so what I think you guys should know is that drug interactions are an important variable for proton pump inhibitors. I'm not going to expect you to know all of the individual reactions. Maybe I think it is important to know the clopidogrel interaction, but just broadly knowing that these drugs can inhibit 2C19 and they can also inhibit absorption of certain drugs, I think that's sufficient. Nursing implications, educating your patients on the signs and symptoms of pneumonia, potential lifestyle modifications, completing the entire prescribed course of therapy, and then separating these medications from antacids by at least an hour. As well as educating on the prevention of long-term effects such as osteoporosis or even hypomagnesemia. That's another long-term effect I didn't mention before. But if you do have a patient that's going to be on these drugs long-term, making sure that they're educated on those long-term problems is important. All right, so let's talk about the last drug that influences acid production, and that is the prostaglandin E1 analogs. So looking at our little diagram, remember these prostaglandin analogs will activate the prostaglandin receptor, and that provides a negative feedback on that histamine receptor. So basically it shuts off that histamine receptor, and that will cause less pumping of acid into the stomach lumen. All right, so the prototype is misoprostol. The brand name is Cytotec. I already described how this drug works. Therapeutic uses. So prevention of gastric ulcers in patients on chronic NSAIDs. So notice that this drug is not indicated for general use for peptic ulcer disease. It's a specific population of patients who could potentially be at risk for peptic ulcers. So patients who are on chronic NSAIDs, using this drug in conjunction with those in an effort to prevent gastric ulcers in that particular patient population. Part of the reason why this drug is limited to that particular population is because this drug has a very important individual variation that we have to talk about, and that is that it's a pregnancy category X drug. And so you guys may remember from earlier on in the semester, when a drug is pregnancy category X, that means that it should not be used under any circumstances in a patient who is pregnant. And for this particular drug, the reason why is because this drug stimulates uterine contractions, and that can cause partial or complete loss of pregnancy. And so in patients who would potentially be using this drug, they have to be educated on this risk. And there are actually some FDA requirements that go along with the prescribing of this drug. And that's why you see on the slide that there are additional therapeutic uses for this drug. It can induce labor. So if you want to induce labor, maybe in a patient who is past term and you want to induce labor, this is a drug that we could use to stimulate those uterine contractions. Clearly, in a patient who is only 10 weeks, that would be detrimental, right? But in somebody who's 42 weeks, the situation's a little bit different. This drug is also used for pregnancy termination along with another drug called mifepristone. And so if there is a reason why that pregnancy needs to be terminated, this is a drug that could be used for that pregnancy termination. Adverse effects, some of the, I guess, less serious adverse effects, diarrhea, does occur with this medication in up to 40% of patients. The good news is that it's usually transient, so it occurs early on, but then it subsides. But letting patients know about that would be important. It can also cause some abdominal pain, and I already talked about the fact that this drug stimulates uterine contractions. Nursing implications, making sure patients of childbearing age are educated on the risks to the developing fetus. And so you guys know, this drug does have what's known as an FDA REMS program, or a risk evaluation mitigation strategy. Basically, patients, when this drug's dispensed from the pharmacy, there are a lot of steps that the pharmacy has to go through to ensure that the patient is an appropriate candidate for therapy. The patient has to be able to comply with birth control measures, so they have to be willing and agree that they're going to do that. They have to be provided oral and written warnings about the dangers of this drug to a developing fetus. The patient has to have a negative pregnancy test within the past 2 weeks, and that documentation has to be provided before starting the drug. And then they're educated to start the medication on either their second or third day of their menstrual cycle, so that they're positive that they are not pregnant. All right, so let's finish this lecture up and talk about the drugs that can neutralize the activity of acid and pepsin. The first one we're going to talk about is sucralfate. Sucralfate, or the brand name Carafate, is a viscousy, sticky gel that basically binds to the ulcer, and it creates a protective barrier. So this drug is a protective drug. Covers the ulcer, and that cover, or that attachment to the ulcer, can last for up to 6 hours after the medication is administered. And so that it basically protects that ulcer, and it allows that ulcer to begin healing because it doesn't have further insult from acid or pepsin that are in the GI tract. This drug is used for peptic ulcer disease. It's pretty well tolerated, mostly because it's not systemically absorbed. It stays within the GI tract. Really, one of the only issues that occurs with this drug is constipation. The other big concern, however, with this drug is that it can inhibit absorption of some drugs. And some of those drugs, that can be clinically significant issues, such as phenytoin, which is an anti-seizure medication, or warfarin, which is an anticoagulation medication. So for those drugs, if absorption is inhibited, that can actually lead to therapeutic failure and put those patients at risk for serious morbidity or mortality. So nursing implications. This drug should always be administered separately from those interacting drugs, such as phenytoin or warfarin. Additionally, patients on this drug should increase their water and fiber intake, and that can help with preventing constipation. And the last drug class that we're going to talk about are the antacids. So here's a picture. This is one of my favorite pictures. There are so many antacids on the market. This is really just a touch of the many, many, many antacids that are available on the market. Patients have a lot to choose from when it comes to antacids.
So our prototype antacid is calcium carbonate, or Tums. The mechanism of action for all antacids is very similar. All of these drugs neutralize acid by reacting with it. Ultimately, they produce neutral salts in the GI tract. There are a variety of different types of antacids. Clearly, the calcium compounds like calcium carbonate, that's our prototype, but I did want to mention some of the other antacids that you may encounter. These medications are very commonly used. I expect that all of you will see these while you're on your clinicals. I expect that as practicing nurses, if you work in the inpatient setting, you'll certainly see all of these different medications. And then, of course, if you work in the community setting, patients will be using these. They have full access to them. They can just walk into the pharmacy and grab them from the shelves. They're all available over the counter. So we have aluminum compounds such as aluminum hydroxide, magnesium compounds such as magnesium hydroxide or milk of magnesia. Sodium compounds like sodium bicarbonate, technically, this is technically an antacid, but we just don't use it. It's too risky for that particular use. And then we have combination products like magaldrate, which is a combination of magnesium and aluminum together. These drugs are used for peptic ulcer disease, for GERD. As I mentioned, over the counter, they're all available over the counter, just for simple heartburn or indigestion. If they are prescribed, the patient would purchase them over the counter. Some individual variation to keep in mind. There should be extreme caution taken for patients with renal dysfunction because these drugs are different salts. They can cause, in some patients, fluid shifts. Some of these, especially sodium, although again, sodium we wouldn't really be using for this particular purpose. But if they cause fluid issues, that can lead to heart failure. Patients with hypertension or heart failure pre-existing, we would be concerned about, or pre-existing electrolyte abnormalities, again, because of the effects of these different salts on electrolyte balance.
Another issue with antacids is that they have the ability to bind a large number of drugs. And that really goes back to their chelating ability. So the whole reason why these drugs work is because they bind ions in the GI tract. So drugs that are polarized have the potential to be bound with the antacids. So for you guys, what you need to know, you don't need to know each and every drug that could potentially bind with an antacid. What you need to know is that these drugs have that ability. And so prior to administration, if you're giving somebody an antacid and they're also getting another medication around the same time, you need to make sure that that drug is okay to be administered concurrently with antacids. Generally speaking, though, we just separate drugs apart from antacids. And usually we separate them by anywhere from 1 to 2 hours, and sometimes even longer, depending on the particular drug. So adverse effects that you should be familiar with, they can cause bowel issues. Some of these drugs cause constipation, depending on the salt, whether they're calcium or aluminum, or they can cause diarrhea, which the magnesium salts can produce. Phosphate depletion, so if you've got a product that's got aluminum in it, that can bind phosphate from food, and that can deplete phosphate, serum phosphate, which can be a problem in some patients. Hypermagnesemia, again, for patients with renal dysfunction. Hypercalcemia, again, for certain patients, hypercalcemia can be a big issue. And so antacids, like I said, so in terms of nursing implications, adhering to therapy, just across the board for peptic ulcer disease, that's an important point. For the antacids that are chewable tablets, make sure the patient understands that they have to chew it completely and then drink an entire glass of either water or milk to flush that antacid down the esophagus into the stomach. And then again, very important drug interactions. These drugs inhibit the absorption of other drugs, so making sure that they're taken at least an hour before or after the antacid at a minimum is important. Now look, for some drugs, the guidance is even to separate them further. There are certain antibiotics that shouldn't be given within 6 hours of antacids. Generally speaking, we say to separate these by at least an hour from other medications.
Okay, so our first question, a patient is prescribed ranitidine and calcium carbonate for the treatment of peptic ulcer disease. What should the nurse teach the patient to do? A, patients on ranitidine should never receive antacids concurrently. B, always take medications together to enhance their effectiveness. C, instruct the patient to take the ranitidine at bedtime. Or D, wait at least 1 hour between the administration of the two medications. So hopefully you all recognize that D is the correct answer. Ranitidine and antacids should not be administered together. It can affect the absorption of the ranitidine. The patient should be instructed to take the medications at least 1 hour apart.
The next sample question, a patient is prescribed amoxicillin and tetracycline to treat peptic ulcer disease. The nurse will instruct the patient that these medications will do what? So take a look at these responses and pause the tape. All right, so hopefully you paused the tape and you had some time to take a look at these responses. Hopefully you recognize that B is the right answer. These drugs destroy the bacteria in the stomach that are causing the ulceration, right? So essentially you're treating that underlying issue of that bacterial infection. They don't they don't have any influence on GI infections that cause gastric bleeding. That's really just a distractor. They don't reduce gastric acid production or alkalinize the stomach fluids. But what medications that we just talked about do? So think about that for a moment. Hopefully you said H2 blockers or proton pump inhibitors or even misoprostol, which is a prostaglandin analog. You may have also said the antacids. Those are responsible for alkalinizing the stomach fluids. They don't necessarily reduce gastric acid production, but they can alkalinize the stomach fluid. And then the last one, reduces secretion of pepsin. Again, this is just a distractor, has nothing to do with the antimicrobial action of amoxicillin or tetracycline that is directed at H. pylori. All right, and the last sample question. Which medication is used to promote gastric ulcer healing that should never be used during pregnancy? So take a look at the list and pause the tape. All right, so hopefully you guys had a chance to pause the tape and hopefully you identified B, misoprostol. Remember, misoprostol can cause uterine contractions, and so patients who are pregnant should not be prescribed this medication. Now, as we said, this drug can also be used to stimulate uterine contractions in certain patients where that is necessary. But the medication would not be used in a pregnant patient to promote gastric ulcer healing. The other medications that are listed, ranitidine, omeprazole, and sucralfate, these can be used in pregnant patients, although, generally speaking, we try to avoid using medications in pregnant patients, but if the pregnant patient does need treatment for peptic ulcer disease or even GERD, these other choices could be appropriate, but each individual patient should be evaluated. Misoprostol, however, never appropriate for a pregnant patient. All right, so that concludes our lecture on peptic ulcer disease. So this is part 1 of our medications for the gastrointestinal tract. Please proceed to part 2, and we'll talk about medications for constipation, diarrhea, and nausea and vomiting. Thank you for listening.
All right, so thank you for listening. If you have questions about this content, you can post them to the discussion board. Thank you.